Hello, my name's Ian McCall, and this is a short video on steroid-induced rosacea. We see this condition much more than we really need to, and that's simply because, for one reason or another, patients apply a strong fluorinated steroid cream to their face for more than about 7 days. When they do that, they get overgrowth of a little mite called Demodex in the skin, and particularly when they then stop the steroid, their immune system reacts to the Demodex, and you start to get these small papules and very tiny pustules coming up on the face like this. The patient then puts the steroid cream back on again. It suppresses the inflammation. The rash seems to disappear. But all that happens is that the area of involvement with the Demodex just increases and goes further and further away from wherever they started using the steroid in the first place. Now, usually, they've probably had a little bit of seborrheic dermatitis in the first place, and they've had a little bit of scale in this area here. And either the doctor's prescribed the wrong thing for them, or, and this often happens, there's a tube of steroid cream in the cupboard at home that's been prescribed for someone else in the family, or for them for something else, and they start applying it to the face. Virtually all steroid creams other than 1% hydrocortisone have a fluorine atom in the molecule, and that increases the potency of the steroid dramatically. 1% hydrocortisone doesn't have that. The percentages of a steroid cream are irrelevant. It's the underlying molecule that's the important thing in terms of the potency or the strength of the steroid. So what happens, they keep using this, the rash keeps increasing, it can extend around the eye as well. And they develop quite frank pustules. And every time they stop using it, it flares even more. And this can go on for months. So how do you treat it? The important thing is you take the steroid cream from them when they come and visit you in the rooms. You don't give them it back. And you prescribe a tetracycline. Now, that can be doxycycline, 50 milligrams twice daily, but just watch for sun sensitivity with that. And they've got to take it with food. And similarly, minomycin can be used as well, same sort of dosage. You can also try some 2% sulfur in sorbline cream. Now, the sulfur will penetrate into these grease glands and will reduce the concentration of the Demodex quite significantly. But you've got to use this combination for at least a month, sometimes 6 weeks, sometimes even longer, for it to completely disappear. And it will disappear without scarring. The other thing you should notice here, notice how the sparing around the vermilion border, most of it anyway, there's often a few millimeters of sparing. That area isn't involved with these little papules or pustules. It's a common feature of steroid-induced rosacea. Let's have a look at some other images. This is just a close-up of that same case there. You can see the small isolated pustules. There's sometimes a wee bit of scale as well. They're usually just small papules that you're seeing. There's a bit of scale and crust under here too. And that's sparing around the vermilion border. This is another example of steroid-induced rosacea. Same sort of picture, isn't it? Look at that sparing around the lip again. Bit more scale in this one, more pustules in this one. It just depends when you've withdrawn the steroid as to how much pustules they in fact get and how good the inflammatory reaction is. The more classic rosacea is this one, where you get a bit of sebaceous hyperplasia, thickening of grease glands. Look how that nose is thickened up. And the small little pustules associated here, pustules through this, they get a lot of flushing as well. With alcohol, hot baths, hot spicy foods, the face will tend to flush. So you've got flushing, you've got papules, you've got pustules, you've got sebaceous hyperplasia. What you don't have are blackheads. Blackheads are really only seen in acne, and you don't get that in rosacea. Here's another example. Typical picture. The redness in that sort of butterfly area. Papules and pustules, very slight scale, not much at all. She may well have a little bit of underlying seborrheic dermatitis as well. Here's another steroid-induced one. This was a steroid cream that was applied to the forehead when it shouldn't have been. looks more dermatitic, this one. There are a few pustules again. Some of these actually might be small milia. This is just where you get a bit of keratin trapped under the skin, little hard white things. But this was steroid-induced as well. If you look at the histology of rosacea, this is the sort of picture here. This is the epidermis. This is a follicle. You often get a degree of blockage just with debris in it, but it's not a true blackhead. These are sebaceous glands down here. This is part of the inflammatory reaction around about a follicle. And if a follicle ruptures, you'll get a granuloma forming there, a mixture of histiocytes and lymphocytes around this. And it's this inflammation that contributes to the inflammation you see, and sometimes you'll get pustules as well. It's interesting, there's usually a little bit of spongiosis, separation of the cells, the keratinocytes in the epidermis with a little bit of fluid around the follicular opening. That's why it can sometimes look vaguely dermatitic. And you've got these dilated blood vessels here as well, contributing to the redness of the lesions. And often there's thickening of sebaceous glands. There's more prominent sebaceous glands. That's why you get that big, thick nose. If you get real prominence of the sebaceous glands, this is the sort of thickening that you can get. You know, we call that rhinophyma. Similarly, a bit here. You can sometimes get it even up in the forehead as well. But that's marked thickening of the sebaceous glands in rosacea. That doesn't respond as well to the tetracyclines and the sulfur and sorbline cream. You sometimes need a retinoid called roaccutane or isotretinoin to try and shrink these down. We've got a few other cases in the consultation series that are variants of it. This is the same thing as we've just been looking at steroid-induced, but this is just around the eye. Look how subtle it is, but again, red, little pustule, some little papules in there as well. Same phenomenon. It's just overuse of a strong steroid. And again, we've recommended there the tetracycline, some sulfur and sorbline to see that settle down. We've another example here. This was, you can see how gross this one is. Now, you initially look at this and you'd think this is some obviously infective process, probably staphylococcal, and certainly you'd be well advised to swab this and just see what you grow. But in point of fact, this was again a strong fluorinated steroid applied to the scalp and forehead. He had had seborrheic dermatitis, which is a little yeast infection with that scale I was talking about. And he'd been applying the steroid cream for about 2 years. And this is the degree of the inflammatory reaction you get when you stop using the steroid cream. Now, again, he was treated. He also grew some Propionibacterium acnes, which is the organism you see in acnes from this. But he responded to the tetracyclines and some 2% sulfur. And he settled, quite markedly in just a couple of weeks. So, go back to the original case, you can see the perils of using strong fluorinated steroids in the face. There are some circumstances when they're required, and the classic example would be discoid lupus, where you do need a strong steroid to suppress it, but that has to be applied very carefully to the individual lesions. There's very few other circumstances when you need to use a strong fluorinated steroid cream on the face for any length of time at all. So, beware of it, be aware of the condition itself. Sometimes the patient, as I say, is at fault. They're the ones who have been using a cream that was someone else's that they've used at home. But this will all reverse with some doxycycline, 50 milligrams twice daily for a month, and some 2% sulfur in sorbline cream. Just prescribe 100 grams of that, put it on twice daily. And this will all just settle down and take the steroid cream from them. Thanks very much.